Now we can have it. They will
Hello, ma'am.
Hello.
How are you?
Good to see you. I'm good.
Yeah, it's good to see you. I'm happy you are here.
Thank you so much. We're looking forward to this presentation. We're actually live on YouTube. So looking forward to it. I think we've got 15 more minutes before starting, so that should be fun.
Yeah, 15 more minutes. And yeah, let's hope in the 15 people will be joining.
No, they will be joining, definitely. Definitely.
Yeah, how was your day?
Great. It's very warm in Ireland. The weather is a bit nice. Who else is connected? Artist, Ars. I don't know how to pronounce your name. Artist, Tid, Arstid.
Aristide, yeah. He's my hospital.
Yeah. And who else is here? Theodore C. I have to learn how to pronounce names from Rwanda. Precious, nice to meet you. Can you turn on your camera?
Nice to meet you too.
Thank you. Thank you so much.
Right. Can't wait people to join. Do you mind? Do you want to see, do you mind if I share the presentation in maybe in box and you see how it looks like so far?
No, it's okay. No problem.
Okay, great.
Yeah.
Yeah.
We trust you. You will deliver. No problem at all.
Yeah.
No problem.
All right, and I believe it's gonna be more of interactive. So I hope it's going to be like open discussion.
Yeah.
Maybe
if it's more interactive.
seeing like other people perception, how people think of things, and how people do things at their home if they face issues. I hope it's going to be more of that.
Yeah, no problem. However it is.
Yeah. So this, I mean, like, is it gonna be shared on like the Operating Room Global YouTube?
Yeah, it's been shared now. So it's on YouTube Live. We are live on YouTube
Already?
Yes.
Okay, that's great. Dr. Yilika, you are most welcome. We are happy to see you. Hello, doctor, can you hear me? Hello, Dr. Yilika, can you hear me? Doctor, good evening, Dr. Yilika.
Good evening.
I'm happy to see you around. We are starting actually in 8 minutes at 8 sharp, so I'll just waiting for more people to join.
የሆነ እያዳመጥኩ ነው። አሁን እንግዲህ መረበሽ አልፈልግም። Johnny, can you hear me?
Yes,
Ca-
yes, I can hear you very
ca-
clearly.
I am visible. I don't want my video to be on.
Okay. I can help you. Let me see.
I will switch it.
Yes, now your video is off.
Okay.
Yes. So I was
So
telling
it's
you
not
that
started, yes?
not yet. You are
He-
still in 6.
Okay. So I am not visible, yes?
Yes, you are not visible now.
Okay. Your voice is not that big.
Oh, you cannot hear me well?
Yeah, a little. Is it my side or your side?
I was expecting my voice to be strong voice.
That's what I know.
Yeah.
Okay.
So we are waiting for more people to come,
So
and
people didn't come in.
oh, no, some people they have already joined. So
Okay.
in 5 minutes we'll be starting, doctor.
Fine. So my video is not visible, yes?
Yes, it is not. I switched off.
Okay.
It's off now.
Yeah, better.
Yeah.
Okay, fine. That's
Right.
good. I will follow you and let me see.
All right, doctor, and because it's gonna be an open discussion, we would love to hear from an expertise like you who have been working through cardiac surgery for a while.
Thank you.
All right.
መረበሽ አልፈልግም። Okay. Okay, can you bring the earphone? No, ትልቁ ቶሎ አምጡ። ውስጥ ይገባል በፊት።
Hey, Danny.
Hey, Jackson, how are you?
Good. Can you hear me?
በቃሽ
Hey, Jackson.
Hey.
Yeah, your line was breaking. I'm sorry, I was not getting you well.
So I was asking if you can hear me.
Can you hear me now? I hope the internet is well. Hello, Jackson.
Hello. Can you hear me?
Yes, we can hear you.
Great.
Yeah. Jackson, is my screen visible to you?
We
Hey,
can see
Jackson.
your screen.
Oh,
Your
thank you
screen is
very much.
visible. Yeah,
Okay, that's great. I was just wondering if
Yeah.
you can able to see
we
my
can start
screen.
in 2 minutes.
All right. Dr. Shiro, how are you? Hello, Dr. Shiro. Hello. Jackson, can you hear me now?
I can hear you now.
Hello, everyone. Good evening, good morning, good afternoon, to depending to where you are right now. We welcome you all to this evening and interesting topic. And to all of you who may be new to this platform, this is the Operating Global, which is an international platform that is aiming to cater for the well-being, improving patient safety, and improving the operative team safety. But the overall aim is just to improve safety of the patients we are taking care of. And today the Rwandan chapter is hosting this talk webinar, and we are honored to welcome Mr. Hakorimana, who is our the TORG Rwanda Chapter Secretary and Public Relations Officer. Today he's going to be talking about the post-operative complications that happen post cardiac surgery. We know all that what it means about post-op complications post cardiac surgery, but what the main emphasis will be how a operative team can approach these complications and how this team dynamics is really involved, and at the end of the day we get patients out of these complications. So Danny is an experienced man working at King Faisal Hospital, Rwanda. He's our most experienced nurse in our theater, and he's got this training on different universities in the country and out of the country. And we are really glad and happy to welcome him to this platform. Of note, those who will be having some questions or some additions, please note somewhere. So when during the presentation, you may have some comments, you go to the message chat, right? Or just note somewhere, so we get all the messages and then ask the questions afterwards. So we welcome you all, and we're happy to be with our Mama founder of the Operating Global. So we welcome you, Dan. Go ahead and Christian say you're gonna hear and change. Thank you. Dan, are you there?
Hello, Jackson. Jackson, hello.
We can hear you.
Dan, can you hear me?
Hello.
Danny, where are you? So while he's just trying to raise up his voice and working on his audio, I'm still admitting some people coming in, and we are really blessed to have you this evening. He's got some internet connection issues, but he's back soon. So please bear with us. So Serge,
Yes,
can
yes.
you unmute yourself and then start reading the bio, and then just tell the attendant who is done.
Sorry, Danny is struggling with.
Yes. Hello, guys. I talked to Danny. He's fixing his audio. So was shut down. So probably in 2 minutes coming back. Is that okay, Danny? Are you back now?
Lino, wait.
Danny, Danny, can you test your audio, please? So Danny is going to use his phone presenting because we can't wait this trouble to we probably not sharing slides, but we have to move on. So, go ahead, Danny.
Hello?
Yes, hello.
Oh, my apology to my audio. My audio on my laptop was failing, so I was trying to fix it, but now I'm going to share the slide in the group, and then now you're gonna bear with me. I'm gonna present why you are not watching the slide. I will try to fix. If fixed, I will share again the slide, but so far let's start. Meanwhile, I'm still figuring out a way to fix it.
Yeah, no problem.
All right, so good evening for everybody. Now, my name, I'm called Dani Hakorimana, cardiac nurse at King Faisal. And today's topic is going to be navigation of postoperative complication in cardiac surgery. So also we're gonna see the strategy to improve the outcome of the different complications that may arise during the cardiac surgery. Now we are starting. There are different complications that may arise during the surgery, especially in the cardiac surgery. So the number one complication is abnormal postoperative bleeding. So the bleeding postoperative still comes as number one complication. So it may arise from different causes. For example, there are different sources like inadequate hemostasis during surgery. it may cause issues. That's why during surgery, surgeon have to be aware, and also surgeon has to make sure that he has done a complete and well done hemostasis. Not only that, but also postoperative hypertension. It may cause issues of bleeding, and also some patients with the coagulopathy issues. Also, they have to get like the very optimization before surgery, because if not done, it causes issues after surgery. Not only that, but also intraoperative heparin that we use to facilitate the cardiopulmonary bypass machine. Also, like every time we have to reverse the heparin. So sometimes it may cause also issues. That's why sometimes the added dose of heparin sometimes is required. There is a different thing that it can show you that the patient who is post-op cardiac surgery is starting bleeding. The very first things, the patient will change with different vital signs. Most of the time we see the patient will go tachycardic. We see also the hypertension will be dropping. We see also the cardiac output will be going down, meaning the patient will be falling in hypertension. Also, if you do labs, also you will see the patient will start going into acidosis. And also HB will start to drop because the patient now will be losing. And also there's another different lab investigation that we do, like if we do study like fibrinogen, we see we go less than 200, and now we start to think, oh, what is happening? Not only that, also PT and PTT also they will fall, and also the platelet will go down. And as people monitoring the patient post-operatively, they have to watch the drains. And drains the very main thing that people have to watch, and because it has numbers, so it determines if the bleeding is usual bleeding or if it is like abnormal bleeding. Like in the very first hour, you have to watch if you are not bleeding more than 100. So when patient is bleeding like more than 100 mL per hour, so now we call it medical bleeding. That is the bleeding that can be manageable with medications. So in that case, you have to start thinking, what is happening? Now it's when you start thinking like what to do. And then if the patient is bleeding now more than 200 ml per hour, then now we call it surgical bleeding. So this bleeding of 200 ml per hour, it might be the cause. Probably most of the time it's coming from surgical, meaning surgical site, meaning on the where the anastomosis was done, where the valve have harvested, or sometime also on stenotomy, on a sternum. Otherwise, when it becomes to be more than 200 mils per hour, now it becomes an extreme emergency. In this case, when the patient is bleeding more than 300 per hour, now the surgeon has to be around, and the surgeon has to open the chest and see what is happening inside, because probably there is like maybe a vessel or a bone or anastomosis which was not done. So the surgeon has to open the chest and see where the bleeding is coming from. Now, if we go down to see what would we do if we have such kind of massive bleeding. So the first thing to do is to correct the issue. Now we have to start giving the patient blood. We have to start giving the patient blood. We have to start giving red cells. We have to start giving platelets. And also we have to watch the blood pressure. Now, meaning we have to start giving the IV support of fluid. Otherwise, you have to give vasopressors so that we can support the heart contractility. The other thing we have to do, we have to give, as I mentioned before, a dose of protamine to make sure that now heparin was full reversed. And we have also to give a dose of tranexamic acid and also DDAVP to make sure that we have full control of the bleeding. And the very main thing that we have to do also, we have to check and monitor closely the blood loss through the drains. And now we have also to watch if the patient is falling into the cardiac tamponade, whereby it will be a very emergency and we need to return in a OR to repair. And if we go to the next slide, now if you see this picture, we start to have like different idea of something that might happen if things looks like this. Then now we see the postoperative infection, which is also number 2 after bleeding. Most of the patients suffer from the infection, and this infection it has to be controlled very closely. It is important to prevent it and to monitor it, meaning we have to take care of our instrument intraoperatively. We have to make sure they are well sterilized. And also during surgery, we have to make sure that our instruments are not contaminated so that it won't cause the post-op the infection. And also we have to take care of UTI, because most of the time also if you put in a catheter and you are not really relying on steroid technique, also it may cause issues post-operatively. And now if you go down to the next slide, we have clinical indications of infection. So now the very first thing you will see and think what is happening, that my patient starting having infection. So the surgical wound now will start looking red. So you will start thinking, wow, what is happening along the surgical site? Because it starts changing the color. Not only that, but also the smelling will be changing and start smelling full. And also the drains from the surgical site, it start to be purulent. You will start to see pus around the site. And also the patient will start having fevers. And in lab investigations, we shall see different things have changed, especially white blood cells, they will go high. And also the urine will turn into cloud urine. So now you will start thinking is that your patient is having an issue for infection. And then if we go to this slide, then now when infection happen, what to do as a team? Now we have to dig together, not only intensivist, not only anesthetist or surgeon. So we have now to involve the whole team to tackle this. Now we have, it is indicated that we do not have to change the dressing at least 7 days, if where possible. When the wound is not draining much, you have to to maximize the day that the wound is closed. And also, you have to develop a dressing changing policy in the institution so that you would know when to change the dressing regarding on the policy you've developed. And when that happens, we'll have the patient has to be on antibiotics so that he can at least tackle the infection. And also you have to do culture and sensitivity so that you will know which microbe is causing issue in the surgical site. And when that happens, you have to do debridement to remove the debris around the surgical site. And also we have to irrigate with fluid, with normal saline, and we have to make sure that we did like a full washout of the surgical site. And then when we go down, you will see something. And when people see this, most of the time you have to directly think of arrhythmia, and which is more common in postoperative. And if we see these strips here, you will see fibrillation. And atrial fibrillation, most of the time it's the very common arrhythmia that happen postoperatively. And it's seen in patient postoperative cardiac period, and most of the time is associated with increased age, like when the old people, they most suffer from the atrial fibrillation. And also if the patient had a history of fibrillation before, also the risk is high. And also increased left atrial size, like when atrium has become big, also it's a high risk. And also previous cardiac surgery, if the patient had a surgery before, so and now he's having maybe like a redo, it's a high risk. And also the patient with COPD, chronic obstructive pulmonary disease, also it's a very high predisposing factor. And the other thing is electrolyte imbalance, like patient with hypokalemia. That's why it is very important and to have like a team involved, like preoperatively, to optimize the patient. If patient has an issue with electrolytes, they have to be sought before the surgery. And also alcohol users, they are at a high risk of developing atrial fibrillation. So now there are different clinical indications that you will see and start recognizing that my patient may have atrial fibrillation. The first thing that mostly seen is fatigue. The patient will lose the energy, and also heart palpitation, and shortness of breath, chest pain, and tachycardia. And most of the time, the blood pressure goes down. So when you see this, you have to see, and you have to do a 12 ECG read to confirm if your patient is not falling in atrial fibrillation. And good enough, in most of the ICU, the patient are mounted on monitors. So when the ECG change, you easily see that the patient is falling in atrial fibrillation. And right away, you have to take the action. So now when atrial fibrillation happen, we have to start giving some medications like amiodarone, like beta blockers. We have to start giving magnesium. And also we have to give an anticoagulant like warfarin to make sure the blood is moving well. And now there is another common thing long on vent machine, also they likely to suffer ventilation acquired pneumonia. That is why it is more advisable a clinical indication of ventilator-acquired pneumonia. Mostly the patient will start having fever. They suffer from tachypnea, most of the time increased secretions. And if you auscultate, you will hear the rocky crackles, reduced breath, and mostly they suffer from bronchospasm. That's why people have to be very aware and near the patient so that they can intervene early. And when that happens, you have to make sure that your ventilator settings are good. You have to reduce tidal volume and also increase inspiratory pressure. And now most of the patients with pneumonia, they suffer from severe hypoxia and as well leukocytosis as infection invading the chest. Now, what we have to do when pneumonia happens, we have to do culture and sensitivity now to diagnose which bacteria was causing issue. Then the patient has to start antibiotics. And also we have to monitor how does antibiotics responding. And also we have to manage fevers and pain related. And also we have to maintain good oral hygiene and also encouraging patient breathing and cough. Yes, so meaning the patient will have to make sure they have done physio regularly and also using spirometer regularly so that they can facilitate the recovery of the lungs. And then another complication that rarely seen is cardiac tamponade, and this is a fatal. So it has to be seen area, meaning now the team monitoring the patient have to be very close to the patient and monitoring the patient very close, because tamponade is when there is bleeding and then the blood is accumulating in the pericardium sac. So it starts compressing the heart, and when the heart starts being compressed, it loses the ability of contractility. Now the patient is at high risk. So how shall we recognize the tamponade? In observation and of the patient, we start seeing jugular vein will start to be distended. And then when you see that, you have to think, like, what is happening? And then another thing that you're usually seeing is plazas paradoxus, where the blood pressure drops during inspiration. When the patient takes a breath, the blood pressure drops. And another thing is tachycardia and low blood pressure, and the cardiac output, of course, goes down. And then this time around, the drains, they stop draining because now the blood is already accumulated around, so it starts draining. Another common recent things in a cardiac tamponade patient is pulseless electrical activities. Now, the patient will have ECG on monitor, but when you palpate and looking for the pulse, you can't find it. And now you have to intervene quickly, because if communication is down or if the person is there is not really watching what is happening, it's easily losing a patient. So now it is where the teamwork comes in, and open communication now here has a big role to help the patient. We have to inform the physicians, the many physicians, meaning the surgeons, and another team have to be involved so that we can help patient as immediately as possible. Then you have to give oxygen, and also we have to manage the blood pressure, giving the heart support, and also we have to do some blood workup to see if patient is deteriorating, and also we have to see ECG, and also we have to check X-rays. We have to check how much the heart is being compressed. So on most of the time also we have to do a ultrasound. And then now if communication has gone well, the patient most of the time has to go back in the OR and open the chest and see what is happening around and being fixed. Otherwise, let's say maybe in case maybe communication didn't go well and surgery is not allowed, the intensivist has to do the emergency pericardiocentesis. And now there is another different thing that might happen as complication of cardiac surgery. There is renal injury, there is neurological defect, there is GI defect, and there is hyperglycemia, and there is anxiety. This might happen during cardiopulmonary bypass. That's why people have to keep in their mind close clamp timing. That's why perfusionists have always to remind surgeon the cross clamp time or during the surgery. And then now let's see what could we do so that we can prevent such thing to happen to our patient, and what could we do to ameliorate our practice. Then now what you have to do first is to optimize the patient preoperatively, ensure that like everything needed has done, especially medical history, especially lab investigation to see if the patient don't have issues, and then if the issues are there, have to be fixed earlier so that during surgery we won't face such things. And then we have also to involve surgical expertise so that maybe the post-op complication will be reduced. Now we have to see if we have the competent surgical team, meaning competent nurses, competent perfusionists, competent surgeons, and also competent anesthesia or anesthesiologist during the surgery, to make sure the team is strong enough to cope with the patient. So now also we have to mind patient selection. We have to carefully select the patient for the surgery based on their overall life status and health status. Some patients, they are very high risk. So if we operate them, meaning the rate of post-op complication will be obvious, will be too many. So in this case, we have to see which patient is going to benefit from surgery and which patient is not going to benefit from surgery, so that he can undergo non-invasive procedures, or he can go with medical treatment rather than surgical treatment, so that we can reduce the complication. And also, as you mentioned earlier, perioperative care also is very big thing to prevent post-op complication, including antibiotic prophylaxis. Like all patients have to receive antibiotics before the surgery, so that we prevent the area complication with infection. Not only that, also we have to make sure that the surgical instruments are very sterile, and also nursing, they're very aware of the instrument not to be contaminated. And also, the other thing is structured postoperative care, meaning that we should have established structure of postoperative care pathway, which is clear and everybody know how to handle the postoperative patient, so that it will be the early detection and early management, so that we can help our patient area. And also, as we mentioned it earlier, multidisciplinary team communication. This is very vital. If the team is not communicating now, or more issue will be rising. Like if he who monitoring the patient see the issue, maybe see the patient is bleeding and didn't mention to intensivist, didn't mention to surgeon, now issue goes very worse. So meaning we have to communicate openly. So the other thing we have to involve is quality improvement project, so that we can always learn from the previous things, previous mistakes. So we have to have an established team that always investigate like morbidity and mortality, so that we can really recognize how to tackle issue which makes our patient more sick or more having more issues. Then also patient education. Here in patient education, it's very important for our patient to be aware of what is really cardiac surgery, and also we have to tell them potential risk which might happen, because sometimes it happens and seems like the family member they were not aware that something might happen, and now it becomes a big issue. So that's why it is very important for us, people who work in a operating theater, to be sure that our patient and also our family, the family member of the patient, has full educated about the surgery. So thank you very much for your kind attention. Now the discussion is open, so we can discuss about these complications. As we are lucky enough, we have different expertise in our meeting, so everybody now is allowed to for discussion. Thank you very much.
Thank you, Danny. As far as we are all concerned with post-op complication, and mostly when it comes to cardiac, it sounds again very important, concerning. So we welcome some questions from the audience, and I saw some of the cardiac surgery into our audience. If there is anything you can be adding, if they are still around, you are welcome. And into the questions and chats, you can go ahead, ask a question, but the discussion is open.
Hello.
Hey, Yurika.
Hi, good evening.
Good evening. Let's
Good
go
evening,
ahead,
Dr.
tell us.
Danny, that's great. I like your presentation, but I just want to give a small comment on 2 points. One is on atrial fibrillation. We give warfarin for patients with atrial fibrillation because when there is atrial fibrillation, there is no organized atrial contraction. That means there is no atrial kick. And the result, there will be formation of thrombus. That is the whole reason we give warfarin, so to make the blood move. The second point is in cardiac tamponade. Cardiac tamponade, it is a feeling problem because the heart is compressed from the external side. There will not be feeling. As a result, there will be low cardiac output state unless we do something to remove that compressing thing, usually fluid. The patient can die. So we should give attention on cardiac tamponade post-op complications so that the surgeon or the interventionist or anybody who is skilled to remove the fluid. CPR doesn't work, whatever. So it is a feeling problem. It doesn't, inotropes doesn't help. It's not a contractility problem. It is just feeling problem. This is just a minor comment on your presentation. Thank you.
Thank you very much, Doctor. I appreciate your intervention. Thank you very much. And now discussion is open. Anybody with intervention is welcome.
Thank you for a good presentation. I have a question because following on this is mostly clinical things and mostly as clinician. Maybe one technology so from the point of view of clinicians, so we deal with bleeding, the IC, but what is the package? What is the package on contact, lifestyle? You have a package with this patient. How do you have when you go home? Just to see and that is probably other. Just give us some highlights of that. Thank you.
All right. Thank you, Doctor. If I heard well, the line was breaking, but if I heard well, you were asking like, what is the package or take-home message for this presentation? The take-home for this presentation mostly is open communication and also involvement of multidisciplinary team, so that when something happens, it have to be tackled earlier, because these things sometimes happen and sometimes patients die. As like maybe patient might have a cardiac tamponade, and maybe he who monitoring is not really aware of how to manage maybe a cardiac tamponade. So now it's where he has to involve the team. He has to ask for a help, and also he has to call for expertise to help, because otherwise, if the communication is not open, sometimes we lose patients because people didn't communicate timely. Thank you, Doctor.
Any other question from the group, from the audience? Hey, Danny, Gaston is now telling us, he was asking if there is, as you're working with the cardiac team, if there is any specific message or information that you give to our cardiac patients so they just take care of and then maybe they be alerted to any post-cardiac surgery complication that you've mentioned out.
All right. As I said earlier, now the very big thing that we could take home in mind is the patient is not for only one person. The patient is for team. As the patient is for team, we all have to be involved and manage the patient holistically. Otherwise, the outcome won't go well. As we have seen during presentation, if let's say maybe nursing team didn't do or didn't mind about study, now the minor issue of infection postoperatively. Now I see like what happened, where the infection coming from. So this is why we have you don't have to keep it. You have to say like my certain instrument now is take away. You have to communicate so that we prevent the complications. The take home for overall of this presentation is working as team, have open communication, and also establishing means to help team to understand what to do and what time to do things.
Oh, Danny, can we allow Christians? I saw her raising her hands. Maybe she has something to tell us. Mwami Kazi?
Yes, yes, yes. Good evening, everyone.
Just go ahead. Good evening.
So if I can start by the last question about if there is clear message given to preoperative patients about those complications. Yes, there is, because there we do preoperative education and we tell them about those bleeding, infection, and other complications which may occur. And that's why at the discharge, we even give them thermometer to check if there is a fever, what they can think about infection or about observing the wound. If there is like yellow, that means there is pus in. If there is redness, think about clotting. If there is swelling, what to think about. So the message from the complication is there, pre-operative, and even after the surgery. Thank you.
Thank you, Christian. So we really appreciate your participative and interactive intervention on this. Wow. Augustin has asked if there is anyone into the audience has experienced any heart transplant. Or maybe some of our attendants from the developed world, high-income countries. Again, Gaston said team dynamics helps a lot, and simulation-based learning is a good model where to learn this. I think this again is a very good intervention. Do you have something to tell about this, Danny?
Dr. Jackson, I have a question.
Go ahead.
I have a question. like 2 questions.
Okay, go ahead.
In a presentation, there was a slide saying about high risk. High risk, and to evaluate those high risk so that we can see if taking patient in surgery will be benefit for him or her. I wanted to ask the team, do we have like checklist and percentage of the high risk acceptance to bring the patient in surgery? Thank you. That's the first one. The second one, there was saying a time of cross cramp to be worried. What really that time to start worrying about? Thank you. Time of cross cramp, which people can start wondering about complication. Thank you.
Hey, Dan, can you have something to say about that?
Yes, I do. Thank you, Christians. I appreciate your intervention. It helps us. So about the close cramp, we have to start worrying. Actually, there is no cross cramp that has to go beyond 150 minutes. So when this happens, the surgeon has to figure out what to do. And most of the time, release cross cramp and rate had refilled again. And after a while, we can also cross cramp again. Meaning after 150 minutes, it is where there is a high risk of the renal injury, neurological deficit, and where the GI gut issue. If I say GI, I mean paralytic errors, because when the intestine stay longer without real perfusion, now they start getting necrotized. The other thing is also hyperglycemia. When the patient is on wrong bypass machine, the body has start to react and I try to be believe the 150 minutes has not. Hello, Queen.
We can hear you. Keep going.
Yes.
Yeah, I think this is what I could say.
Danny, do you have anything to tell about patient selection and the just outcome, something like?
Yes, on patient selection, I wonder, is Dr. Chiro still around? On a patient selection, we have to really optimize the patient selection, because otherwise, if we don't optimize the patient selection, now now the complication is high, because there is some stages that the patient is variable. I mean, it's he only profiting from the non-invasive procedures, like just the patient will have more complication and die. Sometimes die on table, or sometimes even if you have already done repair or replacement, but the outcome is very because the patient was very unfit. And about this patient selection, we have to be very cautious. And also as team, I think we have to have like a checklist, which mention which patient should we take for surgery and which patient we don't have to take. Because some patients are unfit and the surgery letting the patient may be surviving for 2 to 3 or 2 months, 3 months.
Thank you.
We die later than dying today, if I would say.
So thank you, Danny. I think we're running out of time, but maybe how our pharmacist question is mostly burning. Is there a way medication reconciliation is concerning in post-op in case of cardiac surgery? We no longer have, maybe some of our cardiac guys can be telling us, is it time to just bring in pharmacists during our post-op management of our cardiac surgical patients? Dan?
I myself, I think they are ready, and it's time now for the pharmacy to come hand in hand and do this. Thank you.
Thank you so much. I thank everyone who really participated into this very interactive session, and we are really very honored to have had Danny presenting. We thank you all for coming and joining this webinar. This is not the last webinar for this. We will always be inviting you, sharing the webinar links for the next sessions. I think it's time to tell you that we end up by here. Our next sessions will be communicated onto the different platforms. And as you know, we've got like an MOU with King Faisal. Some people from King Faisal will be invited again. And please communicate, transmit this information. But the real message take out of this presentation is we need to know who are really our patients. Patient selection is paramount on just according to the post-op complications. And then a perioperative team around the patient should be aware of what might happen and then communicate ahead. I liked most the information we need to give to the patient before they go home, which is very important. As we know, infection can be happening like 30 days post-op. We can have coagulopathies post-op. So we need to be just giving these like a cards, having all this information. I like the King Faisal team that you're giving even supporting equipment and materials to our cardiac surgical patients. Thank you so much. I think we end this webinar by now. If there is no burning question so far, we will still keep answering all these questions. I think Gaston, Jackson, Danny, and the other King Faisal team are there, and then you can just reach out to us. You can even just talk to us via calls. We can just be handling some of the other burning questions. Thank you so much. I think we call it a day.
Thank you, everyone. Bye.
Thank you so much, and good night.
Good night.
Bye.
Good night.
Good night.